Welcome to the mini lecture on thermoregulation. Thermoregulation is the concept, and your exemplars are hypothermia, hyperthermia, and fever. By the end of this lecture on thermoregulation, you will be able to analyze the physiology of thermoregulation, differentiate among alterations in thermoregulation. You will be able to discuss nursing assessment for clients with altered thermoregulation. You will identify risk factors that increase the risk for altered thermoregulation, analyze nursing interventions for patients with alterations in thermoregulation, and lastly, you will be able to explain health promotion for clients with altered thermoregulation. So before we get started, let's just look at what thermoregulation is, or the definitions that I have taken from 3 different resources. Thermoregulation is the process of maintaining core body temperature at a near constant value. It is the body process that balances heat production and heat loss to maintain the body temperature. And lastly, another definition is that thermoregulation is the process of maintaining core body temperature within an optimal physiologic range. The normal body temperature range is between 35.9 to 38.6 Celsius, or in Fahrenheit, it's 96.7 to 100.5. Let's look at the differences between what a body surface temperature is and the body core temperature. So a surface temperature is that temperature of the skin or the subcutaneous tissue and fat, and it fluctuates in response to environment. So if it's hotter in the environment, your body surface temperature will be warmer, as opposed to the core body temperature. So the core body temperature is that temperature deep within the body. So it's intracranial, which is inside the head, intrathoracic within the chest area, and then intra-abdominal within the abdominal or abdomen, the belly area. And the core temperature is the most reliable assessment data that you can collect when assessing a client's temperature. So there are a variety of factors that affect body temperature. Some of the factors include age, biological sex, physical activity, state of health, and environmental temperatures, like we discussed in the last slide. Body temperatures also can vary based on your circadian rhythms or the time of day. So temperatures typically are lowest early in the morning and highest in the late afternoon, with a peaked elevation of a person's temperature between 4 p.m. and 8 p.m. It's important to know that older adults lose some thermoregulatory control as they age. So body temperatures in older adults may be lower than the average adult temperature. So let's look at the physiology of thermoregulation. The body continually produces heat as a byproduct of metabolism. And when the amount of heat produced by the body equals the amount of heat lost, then the individual's body temperature remains within a normal range, and the individual is in a heat balance, or this thermoregulation, or in homeostasis, if you will. As long as the heat production and the heat loss are properly balanced, then that body temperature can remain constant. And I've listed here the different components or different sources, if you will, of heat production and heat loss. So we're going to talk a little bit more about these in the next couple slides. You don't have to memorize this. I would just want you to be aware of the physiology of thermoregulation. So there are a number of factors that affect the body's heat production, and we're going to go over these 5. Again, you don't have to memorize them. I just want you to understand the balance of heat production with heat loss or heat transfer. Basal metabolic rate is the rate of energy that the body uses to maintain essential activities, such as breathing, and metabolic rate decreases with age. In general, the younger the individual, the higher the BMR. The older the individual, the lower the basal metabolic rate. The second factor is muscular activity. So muscular activity, including shivering, increases that metabolic rate. As a matter of fact, all muscle activity produces heat, will increase that metabolic rate. Thyroxine output is when the thyroxine level increases, it will cause an increase in the release of epinephrine, which in turn increases vasoconstriction, which is when the vessels narrow, and it can either block flow or less blood flow gets through. And this process accelerates cellular metabolic rate throughout the body, producing heat. The next one is the sympathetic stimulation or stress response. These hormones, epinephrine and norepinephrine, are hormones that are neurotransmitters, and they initiate or mount this sympathetic nervous system response that increases cellular metabolism, therefore producing the heat. And then lastly, fever. Fever is a protective immune response, and we're going to talk more about this later in slides, but it is a protective fever is a productive immune response to foreign antigens that are within the body, and it will also cause an increase in cellular metabolic rate, which further increases the body's temperature. So all 5 of these factors are affecting the body's heat production. So to be able to predict how your patients will react to their thermal environment, the nurse should know the 4 ways in which heat transfer takes place from one object to another. Conduction. Conduction's the process of heat transfer through physical contact of one surface with another surface. Great example of this is if a newborn is placed on a metal changing table. The heat from the baby would transfer to that surface and make the baby's body colder. Convection is the process of heat transfer through fluid motion of air or water across the skin. And another example of that, or an example of that, would be like water exercise, when water flows against the movement of the body. So your body's moving in the water. The water's colder than the body. If it is, then the heat from the body is transferred to the water. So to maintain the body heat, the individual must keep moving, that physical activity. Radiation is the process of heat transfer with no physical contact. So this is such example would be sunshine transfers heat to a person who's outside enjoying that warm outdoors. So that's that radiation, that heat transfer to the person. And then lastly, evaporation is the process of converting water to a vapor. So the evaporation of sweat, for instance, in which heat in the sweat is transferred to the air, is a natural process to cool a body when it gets heated. These are just visual pictures of all 4 of those heat transfers, so that you could maybe get a better understanding of what I just went through on the last slide. If some people are visual learners and like the pictures, so hopefully that'll make a little bit more sense. And again, I don't want you to memorize this, but I want you to understand the concept of thermoregulation and the balance between heat production and heat loss. So going back to that thermoregulation concept, the system that regulates the body temperature has 3 primary components. The first one being sensors, the second one being the hypothalamus in the brain, and the third one being an effector system that adjusts the production and loss of heat. Most of those sensors or sensory receptors are in the skin. And the skin has more receptors for cold than warmth. So the skin can detect cold a little bit more efficiently than it can detect warmth. So this is really the meat of the physiology of thermoregulation. So the sensors in the hypothalamus, when they detect cold, so like when the body becomes chilled, the sensors in the hypothalamus are stimulated and they send out signals to increase heat production and decrease heat loss. So therefore, you're going to see the patient shivering, which will increase heat production and make the body warmer. It will also make the body sweat less, or sweating is inhibited. And by inhibiting sweat, if the patient doesn't sweat, it's going to decrease the heat loss. And then vasoconstriction, we talked about it in a couple slides ago, will also decrease that heat loss. Remember, vasoconstriction is when the vessels carrying the blood to the body become narrower and blood flow is slowed or blocked, okay? So that's the left-hand side of this slide when the body becomes chilled and what the brain is doing in that instance, that whole thermoregulation process in the brain. So on the right-hand side, when the body becomes too hot, those sensors detect heat and the sweat glands become more active and you have vasodilation, which occurs to increase the heat loss. So the body's trying to cool, the brain is trying to cool off the body. So when those heat sensors are stimulated, they send out signals in order for the body to reduce the body temperature by decreasing the heat production and increasing that heat loss. Here's some terms you need to be aware of. When the heat is balanced, when the heat production and the heat loss are balanced, you have a normothermia. So your body temperature is within normal range, anywhere from 35.9 to 38 degrees Celsius, which is also 96.7 to 101.5 Fahrenheit. When the body produces more heat than is lost, then you have a condition that's called hyperthermia, which is when your core body temperature is above 38.5 and above the body is unable to control the body temperature due to exposure to that excessive heat. When you have more heat than is lost, then the patient will exhibit hypothermia. So the core body temperature is below that 35 degrees. I skipped right over fever because fever is a type of hyperthermia because it's an increase of normal body temperature, but it is specific to a immune response. So if somebody has a fever, that is a type of hypothermia that is responding to an infection or a disease process. So the maintenance of the body temperature, thermoregulation, is like a continuum. You have the normothermia in the middle, and then I have the arrows depicted here. Hypothermia, when it's lower than regular, is on the left, and when it's higher, you have hyperthermia. Remember, those thermoregulatory centers are in the hypothalamus, and that is what regulates the temperature. So let's talk about the concept of hyperthermia. So heat-induced illnesses are basically caused by the loss of electrolytes or the loss of body fluid volume, okay? And the heat-induced illnesses can vary from mild to severe. So the severe or most serious of these heat-induced illnesses is called heat stroke. Heat stroke is an acute medical emergency, okay? And it typically occurs because of really hot temperature and high humidity, and the hypothalamus, the thermostat center, is unable to regulate the temperature. So the body loses the ability to cool itself through the sweating. The skin becomes dry and flushed, and you can have brain swelling, which is cerebral edema. You can have central nervous system dysfunction. The whole vascular system collapses, and you can have organ failure and even death. So that is by far the most serious medical emergency. You can also have other heat-induced illnesses, such as heat exhaustion and heat cramps. And the causes of heat exhaustion are the same as heat stroke, but it's it's less emergent. So the patient may exhibit dizziness and low blood pressure, weakness, and in some cases they can lose consciousness. LOC is loss of consciousness. And that is due, again, from the body fluid volume. They're losing too much body fluid, and they're losing the salt and the electrolytes in their body, and their body cannot compensate. So heat exhaustion is something like, it might be you're out in the sun playing tennis, and you're not rehydrating with the water that you should be having. So you can have this heat exhaustion. Heat stroke, on the other hand, is an emergency. It's more severe. Another exemplar is fever. Okay, and fever is when the body temperature increases above normal. And what's really important to know about fever is that it is a protective response. So it's a complex process that the body produces in response to foreign antigens. So it causes increase in cellular metabolic rate that further increases the body temperature. Most common symptoms of pediatric patients in the ER is a fever. So most pediatric or children that come into the emergency department have fevers, and most common causes of those fevers in children are infections. Okay, but you need to know that most fevers are not harmful. When the temperature rises to 104 degrees, it can get very harmful, and children can have seizures. But you need to know that most fevers are self-limiting, and they are a part of the body's defense mechanism against infection. A client that comes in with a fever, you will see typically they complain of a headache, they complain of loss of appetite, they can be hot, have dry skin, flushed skin, be very thirsty, be very tired or fatigued. They might complain of muscle aches. And a fever will cause the respiratory rate and the pulse to increase, which is an important thing to know as you're obtaining vital sign assessment data. Another thing that I want you to be aware of is a client that has a fever is called febrile. So the client is febrile, is somebody that has a fever, and the client that does not have a fever is called afebrile. Those are important terms to be aware of when you're talking about a fever. So let's look at interventions specific to someone that has a fever. The biggest thing is you want to identify that cause and treat the symptoms. So I just talked about how children that come into the emergency department a lot of times have infections. So if the fever is caused by an infection, let's say a bacterial infection, then that patient will need to get on an antibiotic to combat the infection. You want to treat the symptoms by trying to bring that temperature down. You're going to do a cool sponge bath. You might use cool packs or cooling blankets, which are also called hypothermia blankets. You want to make sure that you push fluids. Oral fluids are really important for people that have fevers, to be able to help the body counteract the high temperature. Another intervention for fever are what we call dependent nursing interventions, which you'll be hearing a lot of because dependent means as a nurse, you are dependent upon someone else, like a healthcare provider, to prescribe a medication such as an NSAID or a non-steroidal anti-inflammatory drug, ibuprofen, naproxen. Another antipyretic is called acetaminophen. A trade name for that would be Tylenol. An antipyretic aspirin can be given to adults that come in with a fever, but never given to children, because aspirin given to children can cause a syndrome called Reye's syndrome. We talked a little bit a couple slides ago about the signs and symptoms of somebody having a fever, and these will overlap with this slide. So heat-related illnesses, signs and symptoms, that someone who has hyperthermia will exhibit these assessment criteria. You will notice that their skin is flushed, warm, or hot to the touch. They'll have dry mucous membranes, which means their mouth will be kind of, you heard the term cotton mouth. They're very dry. A lot of times babies that are very dehydrated and having hyperthermia won't cry, right? So their mucous membranes are dry. They might have a decreased urine output. They could exhibit dizziness or nausea and vomiting, that fatigue and muscle cramping. They could even faint if they're having CNS or central nervous system issues. Tachycardia is increased heart rate, and tachypnea is increased respiratory rate. Be comfortable with those words. If a patient gets to the point where their blood pressure drops, or they are hypotensive, hypotension is low blood pressure, or they're having seizures or irritability, confusion, stupor, or coma, which are all CNS symptoms. Those are late signs of heat-related illnesses, and you know that your client is in some serious trouble when they exhibit those signs and symptoms. So let's look at hyperthermia interventions. So before you do interventions, you need to know what your goal is. So if hyperthermia is increased body temperature, know that the goal to your interventions will be to reduce the high body temperature. And you need to reduce that high body temperature as quickly as possible. Mortality or death by hyperthermia is directly related to the duration of hyperthermia. The longer that temperature is elevated, the more chances the patient is going to die. You need to minimize any kind of neurologic or cardiovascular complications, and you do that through these interventions. So first and foremost, you want to identify those underlying causes. Again, if it's an infection that's causing that hyperthermia or fever, we want to address that. You want to remove any excess blankets and clothing. You're going to be monitoring the vital signs and EKG or heart rhythm very consistently. You're going to be monitoring their level of consciousness, administering antipyretics that are ordered or prescribed. You will be hydrating them with IV fluids. If they're able to drink oral fluids, you can also hydrate them with oral fluids. But if we get to the point where they're unconscious or exhibiting central nervous system symptoms, they obviously won't be able to drink fluids, so they'll need to be hydrated through the IV. You can place cool packs or ice packs at the neck, groin, chest, and axilla, and you can spray some tepid water. A lot of times we'll do that as you're using a fan to cool that body. Elevate the feet to help with that, the blood flow to the central part of the body. Using a cooling blanket or a hypothermia blanket. You might need to immerse them or place them in a cool bath. If the patient gets bad enough where they need oxygen, you may need to give them some oxygen. If the patient is extreme hyperthermia, you will need to try to cool them off with more aggressive measures, such as gastric or colonic lavage. So that would be putting a tube down and infusing their abdominal cavity with cool fluids. Their IV fluids might be also cooled in order to try to be more aggressive in lowering that temperature. And you really, really need to know that while you're doing all of these interventions, you will be constantly evaluating their temperature, their core temperature, and you stop that cooling process when you get the temperature, body temperature around 38 or 100.4 degrees. Now let's talk about the exemplar of hypothermia. Hypothermia is when the core body temperature is below 35 degrees Celsius or 95 degrees Fahrenheit, and it can range from mild to moderate to severe. You need to know that temperatures as low as 28 degrees Celsius or 82.4 or lower can cause cell, tissue, and organ destruction. So that obviously is the severe end of it. You also need to know that the body can tolerate lower temperatures in a controlled situation. So there are instances where surgeons, per se, or when patients had head trauma and they need to decrease their energy expenditure, they can lower that body temperature in a controlled situation as low as 33 or 91.4 degrees, and the body can still sustain itself. There are three physiologic mechanisms of hypothermia, right? So excessive heat loss will cause hypothermia. Inadequate heat production to counteract that heat loss, which we talked about in the first couple slides, or if the hypothalamus is impaired, if something's wrong with that thermostat in the brain. All of those are mechanisms that create hypothermia. Signs and symptoms of hypothermia. The skin's going to look more pale or cyanotic, cool to touch. Their capillary refill time is going to slow down, and you might not be aware of what that means yet, but the capillary refill time is it gives you an indication of how well the body is being perfused. The client may have shivering. Shivering is that mechanism where the body's trying to, remember that muscle activity, we're trying to increase heat production. But if it's severe enough, they might not be able to shiver. They might not be able to try to activate those muscles and increase the heat. They may have decreased urine output here in hypothermia as well, poor coordination, confusion, stupor, coma, and cardiac dysrhythmias or rhythm abnormalities to the heart. In late signs of hypothermia, in severe cases, you're going to have low blood pressure, and the heart rate and the respiratory rate are going to start to decrease, which is called bradycardia and bradypnea. So I hope you're realizing there are some similar signs. So as the patient is deteriorating or progressive deterioration, you're going to see more signs and symptoms that relate to the central nervous system being affected or the cardiac system being affected. And that is true on both ends of altered thermoregulation. So hypothermia interventions, you want to make sure that you remove the individual from the cold. Again, you want to monitor their vital signs and assess their skin color and temperature very often. Apply warm blankets or warm clothing. If you can, you want to provide a warm environment. Provide dry clothing if the heat loss is due to that evaporation we discussed. Keep the limbs close to the body. The next slide, we're going to talk a little bit about frostbite. Because a lot of heat is lost through the head, you want to make sure that you cover the head with a cap or a turban. You could use a heating blanket or a hyperthermia blanket to increase that body temperature. If it's severe enough, you will want to administer warmed IV fluids. If the patient is conscious and able to swallow fluids, you'll want to administer or provide them with some warm oral fluids. and use heat lamps, hot water bottles, or heating pads to increase the body temperature. But I want you to make sure that I've made a note here that says monitor skin closely. So whenever you're using a heat lamp or heating pad, you want to be very vigilant about monitoring the skin so that there is no damage to the skin or skin integrity stays intact. So frostbite is trauma from exposure to freezing temperature, and it's when you have freezing of that intracellular fluid, and the fluids in the intracellular spaces are frozen, and it then results in cellular and vascular damage. The body parts that are most frequently affected by frostbite include the feet, the hands, the nose, and the ears. And frostbite ranges again from mild to extreme. So first degree is more mild. Fourth degree is extreme. So first degree, you're going to see signs and symptoms. The extremity is going to have redness and erythema, redness to the area. In fourth degree, you're going to have full depth tissue destruction. So the extremity is going to look hard, cold, may appear white or blue-white or mottled, and will be insensitive to touch. When you are trying to institute interventions, you want to make sure that you're doing rapid rewarming, but that rewarming is very controlled. What I mean by that is let's say the extremity that has frostbite is the hand. You'll be placing that hand in a circulating bath of warm water for 30 to 40 minute time spans, and you will be monitoring the integrity of that skin throughout. You will definitely want to make sure that you administer analgesics or pain medication while you're in this rewarming process, because as the blood gets to those extremities, it's very painful. Make sure that you do not massage the body part, you do not handle the body part, and if possible, you want to elevate that body part to help control swelling. After rewarming, so after you've gone through the rewarming process, you will be making sure that the client does active range of motion to the affected digits. So if it's the hand, again, they're moving those fingers actively and encouraging restoration of function or prevention of contractures. Contractures is when the extremity it kind of gets stuck, if you will, and it's unable to, you're unable to use the hand like you're supposed to use the hand. So the function of that hand is impaired if there are contractures. So let's talk about risk factors for altered thermoregulation. Infants and older adults are very vulnerable to both hypothermia and hyperthermia. So the infants have underdeveloped temperature regulation capacity. So they don't have the ability to regulate their temperature as well as an adult does. Oftentimes infants are not as well nourished, and the low birth weight infants are at greater risk for hypothermia, so they can't maintain that temperature. They have the lack of ability to conserve the heat. They have limited subcutaneous fat, so they're not as insulated. And because they're infants, they're completely dependent on their caregiver to control that external temperature to help them regulate their body temperature. Older adults are at risk, higher risk for altered thermoregulations as well. Older adult temperatures usually range lower than average than adult temperatures. I have listed here 97 to 97.4. We talked about that earlier when we talked about body temperatures varying by age. Temperature elevation in pathologic conditions is diminished with older adults, so they may not exhibit a fever if they have infection. Oftentimes, patients that are older adults that have infection, you don't know it until they have behavioral changes, so they might not have a fever with an infection. Normal changes as individual age also put them at higher risk for altered thermoregulation. They have less sweat glands, and the sweat glands are not as efficient. They have reduced circulation, and their vasoconstrictive response is decreased. They have reduced shivering response, reduced physical activity, and reduced perception of hot and cold. A lot of times older adults have lack of resources, so they might keep their thermostat really low because they can't afford the heat, or they may have dementia or altered level of consciousness, so they don't know to dress according to the varying temperatures in the environment. And oftentimes older adults are on medications that will impact how their body responds to extremes in environmental temperatures, which puts them at risk for altered thermoregulation. Other at-risk populations include low socioeconomic status. Oftentimes, the homeless are out in extreme cold, extreme heat, and they lack the resources for adequate clothing. Their environment puts them at risk of altered thermoregulation. People that live in very cold or very hot climates are at risk for altered thermoregulation. I was reading in my preparation for this presentation, I was reading that there are hundreds of children, and you have heard it on the news, I'm sure, as well, hundreds of children annually that are left in cars for extended period of time, and they are at risk for hyperthermia in that instance, and heat stroke. I hit on this a little bit on the slide with the older adults being at higher risk. But you don't have to be an older adult to have impaired cognition. Anyone that has impaired cognition or is unable to reason through, so they might not recognize the dangerous extremes in temperature. If they recognize it, they may not have the capacity to react appropriately. Alcoholics, people that abuse drugs, all of those individuals are at risk for alterations in thermoregulation. People with chronic illnesses, diabetes, heart failure, kidney issues, all of them are at higher risk for thermoregulation. If someone is unable to walk as well, so in this slide it says gait disturbances, so maybe they can't generate the heat because they're not moving around. They have impaired mobility, so they can't generate heat. Traumatic brain injury, people that have a damage to the hypothalamus, which is the thermostat that regulates our body temperature, they are also at risk for alterations in thermoregulation. People that have poor nutrition or poor hydration, people that are in the OR for a long amount of time, all of those individuals are at higher risk for hypothermia, or lower than normal body temperatures. There's something that I want you to be aware of. We haven't talked much about it, but it's called malignant hyperthermia. And that is a genetic disease that increases a patient's risk when they're having anesthesia, and it can be fatal. So if you've ever had anesthesia and they've asked you if you've ever had any issues with anesthesia, they're probably trying to get at this malignant hyperthermia, and you don't need to know much about it at all. I just want you to be aware of it. Inadequate clothing, cold water, recreational or occupational exposures. So, for example, I have some individuals that are out in the extreme heat right now painting my house. They are at risk for hyperthermia. If someone is doing work on a street up in Minneapolis in the dead of winter, they are at risk for hypothermia. So those occupational exposures and recreational, you're out skiing, or you're a marathon runner in the summer, all of those individuals have increased risk for altered thermoregulation. So let's talk about health promotion for altered thermoregulation. So the best way to prevent altered thermoregulation is by education, right? It's to not put those individuals at risk. It's to make sure that there are public health announcements about looking in your back seat of your car to make sure you don't leave an infant in extreme temperature in the vehicle. So you need to address the people at risk for altered thermoregulation. You need to try to maintain appropriate environmental temperatures, promote healthy thermoregulation. So in cooler temperatures, make sure that the individuals are wearing lighter clothing, make sure that, heavier clothing in cooler temperatures. So they're wearing a sweater and a jacket. We're swaddling the infants. We're putting hats on the infants' heads so that they can maintain their body temperature. In cooler temperature, people are moving around more. We want to make sure that they are aware of when they're out shoveling the driveway, they are out there on a limited time frame. In warmer temperatures, this is where we want them to wear lightweight clothing that can breathe. And we prevent dehydration by making sure that they're hydrating when they're out in the heat. We're looking at the individuals who are on medications to see if those medications can cause dehydration. We're making sure that in extreme hot conditions, people have air conditioning. They have fans that can circulate the air. They have the ability to do cold showers or baths or have ice packs on hand. So preventing the extremes in temperatures and promoting a healthier approach to eliminate the risks for altered thermoregulation. And patient education is vital in health promotion. So as we're learning conceptually, I want you to always finish your reading or your research on the concept and think about what other concepts relate to the one I'm learning on. So thermoregulation. Thermoregulation is the concept we've been discussing in this presentation. Thermoregulation is obviously related with tissue integrity if we're talking about frostbite and hypothermia and how extremes in altered thermoregulation can affect the tissue integrity, fluid and electrolytes. We're talking about dehydration, nutrition. If somebody's undernourished, they're at more risk of alterations in thermoregulation. Intracranial regulation. Again, the hypothalamus is the area that regulates the body temperature. So there are a lot of interrelated concepts within or exemplars within intracranial regulation, thermoregulation, and perfusion, how the body, how the blood goes through the body and perfuses the body. So take a look at this concept of or diagram of interrelated concepts and kind of get your head around how thermoregulation is related to these different concepts that you will be learning throughout the semester and throughout your progression through the nursing program. Thank you for listening to this mini presentation on thermoregulation. As always, please let me know what questions I can answer for you so that I know I've done my job properly. Let me know what questions I can answer for you. Reach out to me whichever way you'd like to reach out to me, or we'll discuss it in class. I hope you have a wonderful day.